Hi, guys, and welcome to the talk about bipolar and our related disorders. I'm going to start off today with kind of a lengthy little vignette of a fella who suffered from bipolar 1 disorder, but it really hits all the points, so off we go. We're just going to do it. The fella starts with saying, I honestly can say that up until the end of college, I had no discernible signs of a mental illness. It was all jump started during finals week of my second to last quarter of college. I was 23 years old. I had one final exam left before spring break. I was on schedule to graduate after spring quarter. I was second in my class in civil engineering. During finals week, a classmate met me at a bar for a pitcher of green beer. I witnessed the bartender mixing the green food coloring into the beer. The rest of what happened that day is a blur, and not a blur in the sense of I got drunk and blacked out, but a blur in the sense that when I got back to my apartment, my roommate said that I looked like I had 30 beers. In reality, I didn't even finish the pitcher. I remember feeling a rush of adrenaline and like my arms were on fire. I remember my hands shaking a lot and a lot of anxiety for the first time in my life. I struggled through the final because I physically didn't feel right. The feeling continued on the drive home from Athens to Canton for spring break. The rush of adrenaline continued. The anxiety built up, and I couldn't sit still at all. My mind was racing. The drive home took what felt like an eternity. I just wanted to get home and tell my mom what I was going on and that I could possibly go to the emergency room. I got home and couldn't sleep or sit still at all. The anxiety multiplied. I couldn't even sit and watch TV. My mom and her boyfriend thought maybe the green beer I drank was possibly laced. Either way, we knew something was wrong, and they took me to the emergency room. I vaguely remember screaming religious statements in the crowded waiting room as I waited. I was admitted to the local psychiatric ward. For most of my life, I was in isolation. I wasn't sleeping at all. I started to have paranoid delusions of grandeur, like maybe I was in here because of a crime I don't remember committing. My mind started playing tricks on me. I totally lost track of time. It felt like I was in that room for months. The only people I saw for days were the nurses and my doctor. They started giving me daily medicine, but for the first couple of days I remember denying it. I thought drugs got me into this mess. How can they possibly get me out? Then for about the fifth time, a nurse told me to once again take my medicine, and I said no. Then she said, "Don't you want to go home?" Home. I didn't even remember what home was. My mind had been racing at 200 miles per hour for like 4 or 5 days, and I didn't remember that I had a home around the corner from this hospital with my family. I was at the point that I began taking the medicine and slowly started recovering. At that time, I was diagnosed as a drug-induced psychotic episode, probably from drinking beer laced with PCP. My doctor said it was probably a one-time thing. I stayed on my prescribed meds for the better part of a year. I did not make it back to college in time to graduate in spring 2007 like I planned. I needed the quarter off to mentally recover. But I returned in fall of 2007 for my last quarter of undergrad classes. Leading up to that time I returned, my psychiatrist claimed I was doing well enough that he gradually weaned me off my meds. It worked out to be that right around that time I returned to campus, I was once again medicine free, for better or for worse. Even still, I had a successful final quarter and graduated in November 2007 with a cum laude bachelor's of science in civil engineering. Before then, I decided that I wanted to pursue graduate school in civil engineering as well, the following quarter in winter of 2008. I was having a great time and very thrilled to see what went into the new research side of engineering, and it was all new to me. I had been off my medicine for quite a while now, and I started to relapse while starting grad school. I started losing sleep again. I started to have grandiose plans like designing and building my own house. I started having racing thoughts turned into religious delusions. During these periods, began to think many different delusional thoughts are in fact reality, and I was stupid to not think this way before. I remember talking to my best friend's ear off about religion on the phone. Sleep was lost night after night until I eventually called my mom in a panic and said something was wrong. She drove me to campus and drove me home and took me once again to the local psychiatric ward. The second episode of mine was more severe. I had fantastical paranoid delusions, thinking I was the Antichrist, the Messiah, or both. I believed the news channels were broadcasting me live on TV as this Messiah slash Antichrist was in the local hospital for all the world to see. I figured that all the people in the hospital hated me for it, as well as all the people watching the news. I had many auditory hallucinations from anyone from my classmates and professor to God. I was once again put on medicine, and this episode was also incorrectly diagnosed as a second psychotic episode and isolated incident. I was forced to withdraw from graduate school, never finishing one quarter. I stayed on medicine much longer and even was well enough to work a year and a half at an engineering firm. Then I decided to commute to grad school close to home. It went well despite being depressed and confused about my mental condition. I graduated with a master's in civil engineering and wrote a 140-page thesis. But once again, a different doctor eventually claimed I was fine and weaned me off my meds right around the time of graduation in May 2012. All this stress triggered my third and most severe manic episode. Life was moving too fast for me, even though I had no insight. I scared my girlfriend while living with her with erratic behavior. I started losing sleep again. I got lost once driving from Cleveland to Canton, and a drive that I had memorized. I was unfit to drive, and I got a serious car accident. I lost the job in 1 week, lost my girlfriend and best friend, and was admitted to the local psych ward on my 27th birthday in December 2012. This episode was an extended mania and did not occur only when I was in the hospital. It included a fist fight with my brother, a run-in with the cops, very risky behavior, grandiose ideas, shopping sprees, auditory hallucinations, and even visually seeing things when I closed my eyes like strobe lights, music visualizers, and even aliens. I was officially diagnosed with severe bipolar 1 disorder with psychotic effects. All three of my episodes were actually severe manic episodes with some psychosis involved. I was put on medicine again, this time for good, and I have been manic episode free ever since, over 4 years now. But at this point in my life, I want more than just self-isolation at home and feeling depressed because of it. I feel like I have a lot to offer this world. My plan for the future includes volunteering part-time to see if I can handle the stress of a part-time job. I will also train for the mental health certified peer supporter soon, as I meet all qualifications and definitely have the lived mental health experience, which could turn into job opportunities. My overall goal is to eventually get back into civil engineering field and continue my degree. My story is not over yet, and I am ready to reclaim my life. So just kind of a classic example there of a person with bipolar 1 disorder. And I wanted to kind of go over that because this person had kind of all of the features there. So they had these delusions, hallucination, grandiosity. You'll see all of that there. Our objectives are as follows. We're going to define some terms related to bipolar. We're going to understand that epidemiology and pathophysiology, and we're going to increase your confidence in care and incorporate that nursing process in these patients. So some famous bipolar sufferers. To your right, you will see Sir Isaac Newton, who was pretty darn amazing. Also, if you kind of look down this list, you'll see some extremely creative minds, and some, as you can see, were a bit on the tortured side of things. So Sir Isaac Newton was kind of known for being this hermit that stayed in his apartment for months and months, and all of a sudden he would just have a few weeks of this heightened creativity, lack of sleep, and in fact, he created the Principia Mathematica, which is like the basics for calculus in like 2 weeks. So these guys are just kind of good examples too of what bipolar might look like. So here's some key concepts that we're going to define. And remember, mood is that sustained emotional tone. Examples of that are joy, elation, depression, anxious, angry. And then that affect is what we're seeing, that emotional reaction associated with the experience. So the things that we can actually see. Mania is an alteration in mood that is expressed by feelings of elation, inflated self-esteem, grandiosity, hyperactivity, agitation, and accelerated thinking and speaking. And then mania can occur as biological or psychological or as a response to substance use or a general medical condition. So your book defines 3 bipolar related mood disorders, and the first and most severe is our bipolar 1. Going down the list in severity, we have bipolar 2 disorder, and then we have the cyclothemic disorder. Another little example, we're going to go with the roller coaster theme here. Being bipolar is like being on a roller coaster ride. Sometimes you can predict drop-offs, and others you just have to hang on because the next turn sends you into an unexpected spiral. Sometimes you are laughing and throwing your hands in the air, and then other times you are clinging, simply holding on for dear life, screaming at the top of your lungs. I thought that was a good description as well. So it doesn't seem like any psych lecture would be complete without the DSM-5 criteria, which even though it is small, I want to go over this because this is kind of differentiates bipolar 1 from bipolar 2 from cyclothemic there. So with a diagnosis of bipolar 1 disorder, the patient must have met a criteria for a manic episode. So the manic episode may have been preceded by hypomania, which we'll talk about a little bit here in a minute, or a major depressive episode. So those really high highs, really low lows. And a manic episode is described as inflated self-esteem or grandiosity, decreased need for sleep, the patient's more talkative than usual, or there's a pressure to keep talking. The patient will have flight of ideas or subjective experience that thoughts are racing. We have distractibility or inattentiveness, which is either reported or observed by the patient. We're going to have an increase in goal-directed activity, either socially at work, school, or sexually, or psychomotor agitation, which is like that purposeless, non-goal directed activity. The patient is also going to have an excessive involvement in activities that have a high potential for painful consequences, like buying sprees, sexual indiscretions, or foolish business investments. So this goes along with that flight of ideas and that grandiosity. And then the mood disturbance is sufficiently severe to cause marked impairment in social or occupational functioning. So we had talked about that as far as mental illness goes, kind of has to have that component where we have loss of functioning there. So by comparison, bipolar 2 disorder is going to have that hypomania plus at least one major depressive episode. And for hypomania, we're going to have this, we'll just read it, a distinct period of abnormally and persistently elevated expansive or irritable mood and abnormally and persistently increased activity or energy that lasts at least 4 days consecutively and presents most of the day, nearly every day. During the period of mood disturbance and increased energy and activity, For that hypomania, the person's going to have 3 or more of the following: an unequivocal change in functioning that is uncharacteristic of the individual when they're not symptomatic. So definitely other people are noticing this change in functioning, change in characteristics there, or disturbance in mood. Or the patient, the episode is not severe enough to cause marked impairment in social or occupational functioning or to necessitate hospitalization. So, in other words, they have ruled out bipolar 1 disorder with that. And then the episode is once again not attributable to the physiological effects of a substance. And then by comparison, our cyclothemic disorder, if we had our bipolar 1 disorder with these really high highs and the low lows, the peaks and valleys, our cyclothemic disorder is going to be more like the kiddie roller coaster, where we're just going to have these chronic mood disturbances that go on for at least one episode of up or a down within 2 months there. Okay, so let's talk a little bit about epidemiology. Whereas our schizophrenia was less than 1%, our bipolar disorders are going to be at about 4.4%, and it's ranked 6th among the world's most disabling illnesses. So once again, the world is hugely impacted by this. There will be up to 50% of those diagnosed with bipolar that will attempt a suicide, and 11 will actually complete that suicide. In bipolar 1, males and females have about the same diagnostic rates, but in bipolar 2, females have the slightly higher incident. Average age, once again, is tragically right at the cusp of us starting out our fabulous careers and adult lives right around in the mid-20s, just like in our schizophrenic patient there. And interestingly enough, there's a higher prevalence in higher socioeconomic areas. Could just be because people are looking or know enough, to look for that diagnosis there. So causes, there's a first degree family correlation. So if a family member has depression or bipolar, then they're likely by 4 to 6 times more apt to pass those genes along to their family members. Twin studies. Twins are kind of interesting. The golden twin study is if you were to get 2 identical or a set of identical twins that were separated at birth. So we weren't going to be able to separate or factor in environment. We were only going to be factoring in their genetics. And it turns out that in twin studies, 70% of identical twins will share bipolar together, and then 5% of fraternal. So there's definitely a family component there. Thought to have a large limbic system / prefrontal cortex pathway component. There's a change in sensitivity of nerve cell receptors, which is why some of our anti-seizure medications work on this. Causes are theorized to also be from a sleep-wake disturbance, so a change in our circadian rhythm. Say we stayed up a little bit late to get a task done, and all of a sudden we had this lack of sleep, and that's what spurred on this bout of our mood disorder there, or hypomania, and then on to mania. And then there's lots of transmitters, neurotransmitters that are involved. This is very closely related to our limbic system, aka our emotional brain, right? So serotonin, norepinephrine, and dopamine are involved, and GABA is also thought to be involved with this as well. So there's a model out there called the diathesis stress model, and it basically means you have to have two things to cause an initial bipolar bout to begin with. And one is your genetic proneness, and then the next would be an external factor that triggered it. And we had talked about in our last lecture, I believe, the use of drugs, such as even marijuana, that can kind of initially trigger this. And I wonder what it was in this fella's case, but I have to imagine that it was either the beer he drank that might have been laced with something, or the stressful events he had going on in his life. So, stages of mania. I listened to a podcast not too long ago, and they're like talking about how nobody really stages mania, but our book does, so you may come across it. We have our stage 1, which is our hypomania, and the symptoms are not sufficiently severe to cause marked impairment in our social or occupational functioning or to require hospitalization. So we're in that hypomanic stage there. We got a cheerful mood, nice rapid flow of ideas, our heightened perception, our increased motor activity. We want to be around everybody, and we feed off of the influence of others, and everybody wants to be around us because we're funny and we're the star of our show, and we've got our creative juices are flowing, and now you can tell why we just kind of want to chase this one around. But then we go into this stage 2, which is this acute mania, and there's definitely marked impairment in functioning. And this usually requires hospitalization. In fact, at the bottom of your page here, one of the podcasts I listen to is by a guy named Dr. David Pewter, and he famously says that every true manic episode will end up in 3 places: death, jail, or hospitalization there. So this is going to be our rapid decline in functioning there. The patient will have this continuous high. They're going to have these flight of ideas, accelerated and pressured speech. They're going to have hallucinations and delusions, definitely these delusions of grandeur, grandiosity. The fella at our original vignette here, he talked about religiosity right there, social and sexual inhibition. There's going to be that very need for sleep. And then finally stage 3, which is delirious. So this is a grave form of disorder, and it's pretty darn rare given the fact that we have some antipsychotic medication that will help with this. And obviously the patient's going to have a labile mood, panic, anxiety. They're going to be completely disoriented with a frenzied psychomotor activity, so lots of purposeless moving. And then there's a potential for the patient to even have death or exhaustion because of this. So, mood stabilizers, and we only have one of them, and we do not give the patient, and we'll talk a little bit more about this a couple of slides down, we don't give the patient antidepressant medication because those have been known to strike up a manic episode. So we have to be really careful with our use of antidepressants in our bipolar patients. But lithium carbonate, it's a naturally occurring element, and it's found in groundwater. And one little known thing is that places where lithium naturally occurs more in that groundwater, there's actually overall decreased in homicide and suicide. So a fellow named John Cade, he was a prisoner of war and ended up in Australia in World War II, did some research on lithium. And lithium originally, because it decreases uric acid, was treated, people that had gout were treated with lithium. So the thought process went that they thought that it was uric acid that actually caused the bipolar. So they did some experiments on hamsters, and then eventually humans. They injected people with bipolar and then schizophrenia, and they really did find that the people with bipolar had a pretty good increase there in their mood and a decrease in their manic episodes there. Let's see here. So therapeutic range, they'll talk about this in your EDGT book as well, or modules as well. But we want it slightly higher for our acute manic phase. And we can give these patients boluses at the beginning. That's not going to hurt them, to get them up to therapeutic range fast. And then for long-term control, we're going to want to be at anywhere between 0.6 and 1.2 for our serum concentration. And there is a risk of toxicity, which is why we follow this very closely. It's also influenced by our kidneys due to it being a salt. And so the amount of water we intake and the amount of salt we intake can change those levels. So they get checked with a fair amount of frequency. Okay, so it may cause some weight gain, dizziness, drowsiness, fatigue, seizures, headache, impaired memory, EKG changes, abdominal pain, nausea, polyuria, hypothyroidism, and muscle weakness. And they go into that in great length in your modules that you're working on. When we take calcium channel blockers, we can have an increase of neurologic toxicity. So lots of confusion with these patients. And then there are medications that can increase the levels, and then aid in that risk of toxicity. So large changes in sodium intake may alter the renal elimination of lithium, and increased sodium will increase renal excretion there. And these patients with lithium kind of tend to live at this like chronic kidney disease state due to all of its salt content. So we should really be encouraging water on these individuals. Next we have anticonvulsants. And this was originally found with valproic acid or Depakote. And interesting little kind of thing there. They used Depakote, created it like early or late 1800s, and used it as an inert solvent. So they were trying to induce these seizures on mice, and the people that, or the mice that had the Depakote solvent, they weren't able to induce that seizures. So they figured out what it was, that it was actually the valproic acid, and that became an anti-seizure medication. So this physician named Robert Post did this electrical stimulus activity whereby they would give an electrical impulse to these mice in their temporal lobes, and they would induce little seizures, and then the mice would have seizures without this electrical impulse. So they made this connection that an anti-seizure medication would potentially kind of trigger our electrical impulses or neurotransmitter stimulation. And as you know, our neurotransmitters and our limbic system are all intertwined there. Some pretty significant side effects with these guys. I'll let you guys read that one on your own. Stevens-Johnson syndrome is an extremely scary one, as well as like lots of hypersensitivity reactions as well. So as for our nursing implications there, we're going to monitor for changes in behavior that indicate suicidal thoughts, assess for a rash, monitor for hypersensitivity reactions, such as a fever or a lymphadenopathy, and we're going to assess seizure location, duration, and characteristic of it. If there is a seizure, we're going to assess mood, ideation, and behaviors frequently. And if the medication is lamotrigine or Lamictal, there is a nice little therapeutic range, so we will monitor the plasma concentrations periodically. Not only that, but Lamictal or lamotrigine kind of binds to albumin, so it can be a little bit unpredictable, which is why we got to get these concentration levels. And then there's some interactions listed below. So with these anticonvulsants, we need to teach the patient not to discontinue the medication abruptly and then report right away if there's a skin rash, fever, or swollen lymph glands. We're going to avoid driving or activities requiring alertness. We're going to wear sunscreen and protective clothing to prevent photosensitivity reactions. We're going to assess and notify healthcare professionals for depression or any suicidal thoughts. We're going to notify healthcare professional for symptoms of aseptic meningitis, which is one of the unfortunate side effects there. Okay, so now we use our calcium channel blockers, and the action for bipolar treatment and calcium channel blockers, such as verapamil and diltiazem and such, are not really clear. They don't really know why it helps, but it does help. Unfortunately, they do not try to use these kind of medications because, like we had talked about, a lot of our bipolar patients are on the suicidal side, and an overdose of these medications can be very, very bad. In fact, I just kind of wrote down all the things that we have to do, like right away in the emergency department, to even give this patient a fighting chance. Turns out that 10% calcium chloride is gonna help us a lot. Okay, and then here's overlapping with our schizophrenia. We can use antipsychotics, especially these atypical ones, or the second generation ones have been known to be pretty good for this population. And in fact, if they're doing so well that most of our patients with bipolar 1 that you guys will see, or bipolar with psychosis, bipolar 1 with psychosis, that you'll see at the inpatient unit are going to be on these atypical antipsychotics. They're just really known to be really great. Weight gain, once again, is going to be the big one that people don't like, as well as a person could have suicidal thoughts as well. I don't know if we talked about this in the schizophrenia lecture. I don't think we did. But these antitypical medications, antipsychotics, or atypical, excuse me, antipsychotics, can create a hyperprolactinemia in the body. So if the patient tells you that they have milk coming from their breast, then they probably do. It's something that you need to look into and make sure they have that procalcitonin level checked, or prolactin. So I'll leave this nursing implications here with our antipsychotics. Once again, antidepressants we use very cautiously because of their potential for putting that patient into a manic episode there. And then anxiolytics can be used during that severe acute mania phase where we want the patient to get back on a sleep cycle that's going to be conducive for for treatment there. And then we use all of our additional therapies that we had talked about, like a psychotherapy, individual, cognitive behavioral type therapy, group and family therapy, and ECT. Obviously, there's going to be some safety concerns with these individuals, like suicide, aggression, and falls. And we're going to want to encourage sleep at all costs, have the patient practice some proper sleep hygiene where there's kind of limited stimulation. We're going to encourage that patient to eat, and then encourage appropriate social interactions. All right, that's bipolar. Thanks, guys.